Good morning, Kim. Are we good to go?
Yep. Good to go.
All right. Thank you, Kim. Well, good morning, everyone. I know we have some folks that are still patching in, but in the interest of time, let's go ahead and get started this morning. I want to thank everybody for joining. My name is Adam Campbell. I'm the Vice President for Patient Safety and Quality at Erlanger. We're going to be talking a little bit today about how we drive quality improvement and safety within a system, and really how we utilize high reliability. We're very fortunate to have D&V as an accrediting partner, and we'll be talking a little bit today about ISO 9001 and how a quality management system really helps propagate quality improvement safety throughout the organization. And my initial comments kind of embodies the key points of what we'll go over today. And I do want to thank and acknowledge the quality safety and service team at Erlanger, and also the Erlanger Health System leaders in frontline, and of course, the UT College of Medicine, through which the collaboration of everyone on the screen is vital for quality improvement safety work. So when we talk about quality improvement and safety, really we have to talk about the philosophy a bit. And the philosophy of quality improvement really boils down to culture and being a learning system. As we see here on the screen, this is from IHI in 2017, where they gave a framework for how we become a reliable, effective healthcare system and safe. Culture really embodies that accountability and teamwork, and really a feeling of psychological safety where things can be brought to the attention of the organization, safety and quality-wise, without fear of retribution. And coupled with that, as you build a safety culture, you really have to become a learning system. And that's where reliability improvement really come in. And it really is an air of transparency and really propagating continuous learning across the organization. And those two things overlap. And where they overlap is really where leadership drives both the safety culture and the learning system. And this leader-driven concept is really a big part of what ISO 9001 2015 is all about. And we'll get into ISO 9001 and what that is in a moment. A study that just came out this year in pediatrics from the Child Health PSO really does a great job of looking at the factors that are related to serious safety events. And these are in children's hospitals. But as you see, serious safety events are oftentimes caused or related to failures in culture. Things like lack of situational awareness, failure to communicate, failure to escalate concerns and find experts to look at situations, and of course, team culture. This is team dynamics, and so on and so forth. So a lot of serious safety event contributing factors are really wrapped around culture. So we have to keep this in the forefront of our minds as we look at safety in general. Hudson, some time ago, delineated the model for safety maturity. And this is really looking at how a system or an organization puts an emphasis on safety. And there's 5 levels that as you increase this, you increase not only the strategic acumen of how safety is looked at, but also how you train and how you put knowledge within the system around improvement science and safety, and also looking at the accountability structure, which again is at a leadership level, which is highly important here. This has been done for years and other high reliability organizations, places like naval aviation, commercial aviation, nuclear power. These are highly complex systems that have fewer than their fair share of errors. Healthcare although very complex, with a high degree of variation, strives also to be what we call a high reliability organization. So what is a high reliability organization? Again, this gets to the culture of how we view safety. Wyke and Sutcliffe did the seminal work on this. They now have 3 editions of their book, Managing the Unexpected. And they say that high reliability organizations operate under very trying conditions all the time, yet manage to have fewer than their fair share of accidents.
So the rest of the people were fine. I checked
So it's how do you take this high variable situation
I didn't.
and organizations and reduce
Lady, but I
risk?
didn't delete her off the list.
Oh, yeah. Yeah, we put a note on her and signed off this
Good
morning.
deal. And then
Hey, Nathan, can we put your computer on mute, please? Thank you, bud. All right, thanks. So high reliability organizations reduce this variability, reduce the risk, and go from what they would call a high risk enterprise to what is known as a high consequence enterprise, where HROs operate to make their systems ultra safe. How do you do this? We're going to talk about this a little bit and how this really applies to healthcare. So a lot of this is about variability. When you look at something like an aircraft carrier, there's a lot of variability in the jet speed, all right, the characteristics of the jet, the level of the carrier as it goes through the water, visibility conditions, sea conditions, choppiness, the training of the crew, standardization of training, equipment functionality in the jet and on the carrier, and the condition of the pilot. Okay, these are all things that cause variability within a system that causes high risk. Okay, healthcare is the same way. As you see, this list in healthcare is a little bit longer. The health patient, equipment functionality, training of the staff, the condition of the staff, burnout, medication accuracy, room setup and cleanliness, on and on and on. All right, so you see the high degree of variability, not only in our systems and processes, but also in the patients themselves. So I would argue when we're looking at a high reliability and being able to do something in a very standardized way with very maximized outcomes, that healthcare is probably the most complex system that you can put this into. So we're expecting great outcomes and very streamlined processes with high degrees of quality and safety in a system that is highly complex. That's the epitome of why we need high reliability. So in healthcare, again, this is from Wyke and Sutcliffe, and this has been delineated out by IHI and Don Berwick and others, is really that definition is the capability of a process, procedure, or healthcare service to perform its intended function in a required time under existing conditions. So these complex conditions, you have to have processes that are very capable. And you have to have in real time a high degree of problem solving, not only on the nursing and physician side and the caregiver side, but we have to problem solve situations in which we work. The environment of care, okay, we'll see when we talk about accreditation and D&B, the environment of care is very important as how we set up an environment in which safety is optimized. So how do we measure quality and safety in healthcare? This is obvious, of course, but in industry, it's really a reduction in nonconformities, and it's that increasing yield. So you want a good product in a timely manner with a reduction in nonconformities. In healthcare, a nonconformity, of course, is infections, falls, untimely documentation, readmissions. These are things we want to reduce. At the same time, we want to increase efficiency. So this is an effectiveness and efficiency model that we're looking at. Improvement science at its core, things like Lean Six Sigma, is nothing but a non-conformity and variation reduction strategy. So there's 2 things we need to do. We need to reduce errors and we need to reduce variation.
I have no idea how to direct you.
We're in the same.
Yeah. But
Nurse over here.
yeah, so that's when it's in
Yeah, Nadia, you're not on mute. Thanks. So as we look to optimize these outcomes, we have to increase reliability. Reliability in healthcare is reducing the number of errors or nonconformities per number of opportunities. So the higher the reliability, the fewer errors. Healthcare performance improvement, HPI, really does a good job of looking at different levels of things that we can do to increase this reliability and reduce these errors. We're optimizing outcomes here. The first is process design. We do a great job of this in healthcare, things like evidence-based practice. We focus and simplify interpretations. We do differential diagnoses. We have care plans. We have care pathways. We have tactical improvements. We've got things like care bundles, bundle reliability. So these are the basics. These are the things on the standardization spectrum that we need to put in place that are very important. The next thing we need to do on top of those process designs is put in a culture that supports safety and quality. So this is a reliability culture. This is things like we have to have safety and quality as a core value within the organization. We need senior leader oversight of this through a quality management system, as we'll see in a moment. We have to hire for fit. We have to bring folks in that fit the mission, vision, values of the organization, and you have to set expectations for behavior, expectations for care, and that goes a long way toward accountability. And finally, the highest level of reliability is really driven by human factors. This is the intuitive design piece of healthcare. This is equipment design, room design, care design. All right, this makes it impossible to do the wrong thing and obvious to do the right thing. And truthfully, healthcare is just cracking the surface of human factors in this regard. So we know things we need to improve. I'll show you how we improve, but how do we know we've improved? Okay, it comes down to the three process elements. Process capability. You have to have a system or the ability for a process to meet your intended goal. This is how it's resourced, it's how it's structured. So you need to have all your processes in line and really increase capability within your system. If folks aren't trained, if things aren't resourced, your process capability is decreased and there's less likelihood for improvement. Process reliability, that's what we're talking about with HROs. These are organizations that have consistency in their processes. These are staff that are highly trained. These are processes that have very low rates of error, and that's what we work toward every day. And the third process element is a process improvement, where you're increasing the process capability and reliability and improving it where you have gaps. And all of this is really built on the foundation of relevant metrics. If you don't measure it, you can't improve it. We need measurements and we need trends to see where we are falling short and where we are improving. So when we look at statistical goals for improvement, really, one, you have to shift performance in whichever direction that you're looking at. So if you want to increase reliability, you want to get to 100%. If you want to reduce errors, you want to get to 0. So there's a shifting of performance that we need to look at. But at the same time, we need to reduce variation. So we need to squeeze our variation around our optimal performance. One thing to keep in mind is you can have very low variation around a performance level that is not optimal. Okay, so just because we reduce variation doesn't mean we're improving totally. We need to have that shift in performance, and that's where change management and quality improvement come into play. They do those two things. Reduction of variation is very based on standardization. Okay, shifting up performance is changing the system. And our good friend Deming always said, if I had to reduce my message for management to just a few words, I'd say it all had to do with reducing variation, all right? You have to be consistent. You have to have low variation. This is what it looks like in statistical process control. If you notice at the bottom here, we're creating a standard. Everything in quality improvement, process improvement is creation of a standard. Once you create that standard, you train to it. That creates your stability within the process, okay? And then you just increase that over time. So as you see here, we're shifting the mean upward, but you can see those control limits, those red dotted lines are pressuring in on performance. So as you increase performance, you're reducing variation. That's all based on the standard. That's high reliability. And we see this all the time in bundle reliability, things we need to do to reduce collapses or CAUTIs or surgical site infections or unplanned extubations or pressure injuries. Everything we do to have that reduction in errors and unintended outcomes is really based on this process control and reliability. We do this through looking at trends, and we have to do trend analysis, because you have to know when you make a change, what is the effect of that change on your performance, okay? At the top, if we show before we do a change, we have a mean of 90, and after the change, we have a mean of 45. You see this all the time in the literature. You can have a statistical significance between 90 and 45. You say, hey, we've improved. But look what happens in the trend. If you look below, before and after change, on the bottom left, you see that you have very poor performance, and all of a sudden after the change, you reduce that performance to a better standard, a better level. In the middle, you have change that happens gradually. You have to doubt and be skeptical about whether that changes, whether that performance change is due to that change that you made. And lastly, on the bottom right, you have a change, but look what happens. You have that gradual reduction, and after the change, you actually see a degradation of the performance. So it's vital to look at trends. The way we do this in healthcare, the way we do this in statistical science is through statistical process control. You statistically look at trends to analyze your baselines and effects of change. And this follows specific rules, and it's what's known as common cause and special cause variation, where you're really looking for special cause, something that is put into the system externally that wasn't in that normal baseline situation or in that baseline system. You're making a change. And what happens is you have these control limits and statistical process control that allows you to gauge this variation, gauge these special causes to see where they are. I liken this to football, where I do goalposts. So if you look at a goalpost and you're looking at someone trying to kick a football, a place kicker, to make a field goal, you have control limits, okay? Your goalposts are control limits, and you want to make sure your performance is a made kick right down the middle. What happens is if you miss the kick, you're going outside of control. You have too much variation, right? If you miss too many, you got to look at the place kicker. You got to look at the conditions in which you're kicking. You have to look at the stadium. You have to look at the football. You have to look at your training. How much do you practice? But you want good mean performance every time with a reduction in variation. So statistical process control charts are nothing but turning these goalposts on their side and looking at your trend. Okay, that center line, that mean performance is going to be what you want to change. And those upper and lower control limits are indications statistically of your variation. Okay, you want to keep your performance within that. And what we do in SPC, statistical process control, is look at these trends over time. These red circles are around things that may be indications of those special causes in your chart or in your trend. So you have to look at these. One of the most important special cause rules you see on the right is 8 points above or below the existing center line or existing mean performance. When you do that, you can do what's called a shift. You can shift your chart up or down in the desired direction because of that special cause rule. You're meeting statistical significance of a trend. And this is what we see in quality improvement, and this is what we want to do when we have any kind of project to start looking at trends in this manner. So that's really the philosophy around this, and that's really how culture fits into this, and we look at variability within a system and the reasons why we want to standardize and become highly reliable. The other part of this is we want to have organizational oversight where you can build a program in this regard. This is done through what is known as a quality management system. You want to build a quality management system in the organization. At Erlanger, through our accreditation processes with D&V, which many of you are involved in, you become certified in what's known as ISO 9001. And this is the 2015 version. And what ISO 9001 is, it's nothing but an international standard that delineates the requirements for building a quality management system. A quality management system is really just a formalized system for quality where you document your processes and procedures and through policies, and you build process improvement, all right? And you build resourcing, and you build oversight and monitoring of your processes and your outcomes within a system. Organizations use this standard to demonstrate their ability to be highly reliable and provide good outcomes. But this is the structure with how you do that. Levitt, some time ago now, this is from 2011, really gave us 3 steps and how you do this through a quality management system. First, you have to define your key processes. What does the customer want and need? Okay, so you define key processes, and it's a basic input-output system. You want to look at your customer requirements. You want to create and define processes that meet those requirements, and your output is customer satisfaction. Do you have good outcomes? Are they satisfied? So on the right, you see here are some things when you define these key processes you have to keep in mind. You need to lower the risk in the processes. We need consistent product, and we need high reliability. Once you define the processes, you have to manage them. Okay, you manage these through measurement, looking at those trends, having management or senior leadership review the processes on a regular basis to look for gaps. Okay, and all of this is built on a system through which you monitor the process through auditing, and you have a controlled document system that documents everything appropriately, from policies all the way through procedures and through your dashboards and metric system. And upon audit and upon review, if you have something that falls out, you need a corrective action plan. This is where improvement comes in. So you have to define, monitor, and measure and manage, and then you improve where needed. And this is where quality tools come into play, like Lean Six Sigma, PDSA, plan, do, study, or check, act cycles, statistical process control. This is all built into the improvement side. And that is based really on the strategic planning at the highest level, looking at the monitoring of this, assessing your risk going into strategy, and then improving where necessary. So this is what I call the QMS, or the Quality Management System Engine. Again, it's an input-output system. You have to look at all of your system inputs within an organization. The voice of the customer, the patient and family, top 10 problem list on the units and departments and divisions. This is where you're looking at risk prioritization. What's most important that we need to improve? Opportunities you get from event management, all right, from things that are put into a system like eSafe. Opportunities on rounds that you find. And of course, there's regulatory expectations and staff and community expectations. And this all goes into what I call the engine. And it gives you system outputs, which is quality outcomes, zero harm, regulatory compliance, on and on. But this engine is all based on ISO 9001. It's centered on leadership in the middle. Leadership strategically plans, supports, and provides solid operations, all right, within the system. They evaluate and monitor the performance of the system, all right, through processes. And if anything needs fixed, you go down to the red and you implement your improvement science methodologies that should be standardized as a system. And that's what you work toward. Whether it's efficiency problems, you use lean, or if it's effectiveness problems and you have to reduce errors, it would be something like Six Sigma. We're looking at error reduction and looking at really putting a plan and a project in place. So through this cycle, you hope to optimize outcomes. So we saw the circle before that looked at culture and a learning system. Well, we saw the engine. All right, that engine is based on surfacing problems, problem lists, looking at the areas of risk, things that need to be fixed. This is all driven by our mission and vision and values. At the top of that wheel is improving quality, safety, and service, okay? So everything we do strategically, we have strategic objectives for the organization. Well, one of those pillars is quality and safety. So we have to optimize this through our mission, vision, and values, and senior leadership and the board really drive this from the beginning. And that allows you, hopefully, if it's resourced properly, that you can become a learning system, right? If you have the proper culture in place, like we just talked about, you can then become a learning system. What does it mean to be a learning system? It's all about process maturation. Do you learn? All right. Are you setting your strategic goals appropriately? Over time, are you operationalizing these goals and improving? All right. So it goes from a reaction to problems, really, to how you get an integrated approach and a systematic approach to how you look at strategic goals in an organization. This is from the Baldrige Excellence Framework. And it really is a national quality award that really helps you not only put things like strategy in place, but how you drive optimal performance. And the other part of this is you want to go from putting out fires to innovation. All right. You want to go and becoming a learning system through strategy as you learn from things that happen. All right. How many times have you heard, well, that's a deja vu event? Well, it's a deja vu event because something happened again that's suboptimal because we didn't learn from it. Okay. Erlanger and other places have processes in place where we learn from situations. Okay. You cannot have improvement science and quality improvement without that learning system aspect. How do you react to problems and learn from them? So the definition by IHI at the Institute for Healthcare Improvement, they define culture as safety as an environment in which providers can discuss errors, near misses, and harm openly. All right, remember that transparency piece of learning system, but it's all based on a non-punitive environment where we can report safety events. All right, so you can have a well-oiled safety process, but you have to report events. All right, we have eSafe here at Erlanger, and the more we put into the system, the more we know what we need to fix. We can do analysis, okay, density analyses on things that are put in there more often than not, and we can see what we need to improve. This creates awareness for the organization. Then we go into causal analysis. We look at those events and we learn from them. We learn from them by trying to find the root causes for why an event has happened. It could be a fall, it could be an elopement, it could be a pressure injury. There's many things it could be, but you have to have that learning environment and do a causal analysis. And once you find those root causes for those events, you need action items, you need action plans for positive change. And this is the improving. So you have to create an awareness through reporting, you have to learn from it through analysis, and you have to improve it through positive change and action orientation. Like I said, there's event reporting systems. We have eSafe. So it's really your opportunity to put things into the eSafe system, and these are monitored and looked at every single day, hundreds and hundreds of event reports. And based on the possible level of harm, those trigger those causal analysis processes. And causal analysis really looks at, and this is James Reason's Swiss cheese model, really of what were those barriers that were not in place or did not work appropriately that caused harm to occur or an event to occur. Root cause analysis finds out the nature of each one of these slices or barriers that did not work appropriately. All right, so it could be a number of things. It could be lack of training, it could be a variation in a system, it could be fatigue, it could be a number of things, poor design of a process, et cetera, et cetera. So this allows us to really break down the different issues that might have occurred that led to harm. That's root cause analysis in a nutshell. And Reasons kind of delineated that out through the Swiss cheese model. So all of this is hinged, all right, reduction in variation, improvement in the standardization of roles and responsibilities, and not only roles and responsibilities, but how they interact with the processes. Are we trained to a very high level to perform a process the same way every time? Right? That's reliability. That's what naval aviation does. That's what commercial aviation does. That's what chemical and nuclear plants do. All right, this high level of training, all right, to where it's almost automatic. All right, you're almost creating things that are subconscious in nature. But I liken this to a Formula One pit crew. Every one of these 21 people, including the driver, are very highly trained. They practice this till there is perfection. Okay, this is the epitome of high reliability. So you see something where they're changing tires in less than 3 seconds. You see that training in action. Think about this in healthcare, right? This is high reliability. If this is reduction of pressure injuries, if this is reduction of serious safety events or CAUTIs or CLAPSIs or anything else, this is the level we need to get to, okay? Highly trained, same thing every time, and we have culture and safety in mind. So how do we do this? Well, we do this through having standardized methods for improvement, okay? You set the culture. All right, we identify problems through the quality management system. We identify them and resource them, and we need to improve processes. So this is where improvement science comes in. This is where the methods come in. And you have to have what I would call a decentralization to the front line of this. Long gone are the days where there's a quality and safety and service, quote unquote, department, okay? What you need to properly have this culture, to properly have this learning system that is really supported by a quality management system is this decentralization where people are trained to problem solve and address problems, surface them and problem solve them at the local level, okay? This is our goal here, okay? This is our goal with nursing, with physicians, with ancillary staff, with everybody in the organization, that we can form teams that allow us to optimize performance and optimize processes. Again, we do this through quality management systems, and it's that improvement science at the bottom, where if we find something in this cycle of inputs that needs fixed, we have methods that we can use very quickly that are standardized. Everybody knows the same method for doing this to improve. And of course, this gets back to Levette, how you improve key processes. You can do this a number of ways. A lot of this is project management. One method for doing this, for managing projects, is DMAIC. You know, you define the problem, you measure the problem, you analyze the problem, you improve, and then you have to sustain or control, which is the C in DMAIC. So you can use project management skills and methods like this to kind of form and make sure projects stay on track. But this is really nothing but change in project management, all right? And there's little specificities within each one of these levels of DMAIC, but it really helps out to have a format. So the first thing we need to do, of course, is identify the opportunities. Not only does this drive organizational strategy, okay, and goals for the organization, but it also helps at the unit and department level, all right, the division level. What are those top 3 things you want to fix? How do we resource them and make sure we isolate that risk and improve it? Here's an example that I like to use. It's really, you know, when you find something that needs fixed, in this case, it's in a children's hospital, hypothetically, where, you know, if children are readmitted or anyone's readmitted, it really is a stressor on the system, stressor on the family, stressor on the patient. So you monitor your readmission rates, and, you know, CMS has actually begun penalizing you for certain types of readmissions. So it's highly important. So we look at 7-day, 30-day readmissions after discharge. And in this scenario, we found that the readmission rates were higher than other similar hospitals. All right. So we want to be best in class. We want to be in the top decile performance, right? So we need to improve. All right. As part of this, we need to implement project management and standardized methods. We do this by looking at our performance. Remember the statistical process control we talked about. You have to look at your performance over time and see where it is to goal. In this, we see the green line, which is the goal of other pediatric hospitals. But our performance is quite elevated. So we need to reduce from about 4.7% down to about 3%. A lot of ramifications of this in that reduction. So once we see this, that's the outcome metric. Okay, we need to break this down. And the way you break it down is, do we need more data? Well, the answer is usually yes. So you have to look at what are, this is hypothetical, What are the service lines that have the highest level of readmissions? You don't want to put your energy into working on something that doesn't have a high rate of readmission. So you need to look at things like service line, characteristics of the patient, and also look at things that may be happening post-discharge, medical equipment, DME issues, education issues upon discharge, medication issues, on and on and on. So you need to look at the exact cases, the individual patients, and see what are the characteristics of that process that broke down that led to readmissions. And you do this as a team. This is not one person doing this in isolation. You have to do a stakeholder analysis. You need to bring the right people into the room. And this is often done, or is helped being done by a project charter. Every project should have a project charter. This is a living, breathing document that allows everybody to see what the goals are, what the structure of it is, what the guidelines are, what the goals are, what the timeline is, and what the governance structure is, who provides accountability for the project. That's all in the project charter. At the very beginning of the project, you need to create what's called a SMART aim. What's your goal? You have to say, what do you want to change? How much do you want to change it? By when? This can't be open-ended. Well, we'll fix it over 10 years, and that's not going to work. And what is the specific population? Remember, we talked about breaking down the data. Is this a specific service line we need to focus on? Is this a specific issue post-discharge that leads to these readmissions? Okay, so you have to do that. And there's aim statement worksheets you can use that allows you to put these different parts of a SMART aim together. So when you look at the what, by how, much, by when, for whom, and where, you get a nice aim statement where you want to reduce readmissions by 15%. That'll get us to that best performance goal. By December 2021 and sustained for 1 year for patients discharged from an inpatient or observation status in the last 7 days. You see how specific that is? That really helps you guide the team, guide the organization on what needs to be done for improvement. The most important thing, once you see the problem and identify it and get a initial goal, is you have to understand the process. You have to put eyes on the process. You can't do this from a conference room. You have to look at the process, you have to observe it. And Toyota production system, this is called Gemba, where you have to see the work where it happens. Okay, this is grabbing a stopwatch, grabbing a clipboard, and going and looking at the process steps in real time. Once you do that, and this is an example of a discharge process and post-discharge, you can then identify where the gaps are, all right? Those gaps are the most important thing that you're going to identify. What you think may be the problem may actually not be the problem. You have to lay your eyes on it. You have to look at the process and identify it. This is very time intensive, okay? This is still defining and measuring and analyzing if you're looking at the MAIC format. This is the first 3 stages, all right? In any project, about 70 to 80% of your work is going to be done up front, okay, before you even improve. One thing you have to guard against is if you have that first stakeholder meeting and you're identifying those goals, is even before you look at the process, folks will want to start looking at solutions. I caution on that because you have to see the process first. You have to see these gaps. Why are these gaps so important? Because they drive your interventions. You should never have an intervention that is not related specifically to a gap in the process. All right, you do not need free-floating interventions. Something maybe seems easy to do, or you can do it and have a quick change, but it may not be related to a gap, okay? The way you can organize this is once you get your SMART aim and look at the process, is you can create a key driver diagram. This is what we see on the screen here, where your SMART aim is on the left, and you have key drivers, things that you've identified with the team and through the process that are those key areas, those large buckets of things that group your interventions. And on the right side, you have a series of interventions that you can then prioritize and knock off one after the other, right? Some interventions may need to be done before others, okay? This is where the team really has to be in tune on improvement science and how this is done, okay? But again, key point, there should never be an intervention that's not related directly to a gap in the process. And the gaps in the process should never be determined in a conference room. You have to look at the process. I can't stress that enough. Once you do that, you can go through the process of rapid change or a change process. This is based on, and I like to use IHI, the Institute for Healthcare Improvement, has the model for improvement, where you ask 3 questions. Every time you do a project, you need to ask these 3 questions, right? And we've seen this. If you've taken the IHI Open School or other trainings, you'll see this. What the model for improvement does is these 3 questions are, what are we trying to accomplish? Of course, that sets the goal, all right, or the standard you want to achieve. How will we know that a change is an improvement? Okay, well, we need to measure it, all right? That's how we know a change is an improvement. We measure it, okay? So we set the goal. What are we trying to accomplish? We measure it to make sure a change is an improvement. And what change will we make that will result in improvement? That's your action, all right? So you have to define it, you have to measure it, and there's action orientation on making sure that the change that you're implementing is the right one. Right? And you do this through a plan, do, study, act cycle. You plan the change, you do the change, you study the effects of it, and you act on it. You can do one of 3 things after a PDSA cycle. You implement it, you measure it, you see if it's having an effect. Usually this is done on smaller scale, right? Like a pilot. You want to just do it for a couple days, a week, what have you, but you want to implement a small change and you act on it. All right. If it works appropriately, you can adopt it. All right. If you need to optimize it and change a little something and redo a PDSA cycle, you can adapt it. Or if it didn't work at all and you just want to jump ship and do another PDSA cycle, you can abandon it. So that's the 3 A's, okay, of ACT. You can adopt it, you can adapt it, or you can toss it to the wayside and get rid of it. So I recommend, and email me, I can get this out to you, PDSA forms. This allows you to properly plan and do these rapid cycles of change. One key point here, of course, is in these PDSA cycles, it really is very important of determining who will do what, all right, and when will they do it, who will be collecting the data, who will be implementing the change, who will be doing observations, et cetera, et cetera. So through this all, like we saw in the Formula One team, you have to have those roles and responsibilities. And someone leading the project has to delineate that out. That's also in the project charter. That's why it's so important. And that really goes through looking at accountability for the project. In the long run, what you want out of this is you go back to statistical process control, right? You're looking at the effects of change. You always, anytime you have a trend and you're analyzing it, you want to put in boxes that show when your changes occurred, all right? Because you want to be able to look at any shifts you may have in performance and how they're related chronologically, temporally, to when those changes occurred. So the way this is set up is you have your basic trend on the bottom, you have the time frame. This is over months, but if you have initial PDSA changes, you might be looking at measurement periods of weekly or daily or bi-weekly. Okay, so you want to look at your time frame through which you're doing this. And initial PDSAs, like we discussed, the time frame may be weeks or days. And on the y-axis on the left is your performance. All right, it could be frequency of events, it could be the rate of events, but this is what you look at over time. And you look at the effects of change. And I like to call PDSA cycles, they happen in what I call ramps. Okay, and IHI talks about PDSA ramps. And this is, PDSA cycles are intuitive, all right? You have 1, 2, 3, 4, and they build on each other. So you have different changes over time that takes you closer and closer to optimal performance, okay? Remember back in the key driver diagram, this allows you to list those interventions that are directly related to key drivers to the SMART aim. Well, this allows you to see as you prioritize them to implement them in a specific manner and far enough apart where you can see the effects of each change. Okay. That's the beauty of statistical process control. If you're more interested in this, please reach out to me and we can work through this together. So you see these basic tools, all right? Project charters, SMART aims, key drivers, PDSA forms. If you do that and just measure everything along the way, That's what you need for a project. Okay, that is, if you have this, it's easily translated into a presentation that can be given at, say, Quality Oversight Committee or other forums, to the board even. All right, but these are the basic tools that would be the expectation we would want to see in every project. How do we learn to do this? Well, the Quality and Safety and Service team is here to coach, gaining training, becoming trained in these methodologies even more, workshops, things of that nature. One good place to go is the IHI, the Institute for Healthcare Improvement Open School. And looking into that, there's different video-based and module-based trainings that you can do to get certificates in improvement science methodology. So to recap, what we have is you got to set the culture, all right? You got to set high reliability as a strategic goal for the organization. You have to become a learning organization. You have to surface problems, all right? This is aided by creating a quality management system so senior leadership can monitor and strategically plan around this and resource it, okay? And then you have to train your staff not only to perform processes optimally to get optimal performance, okay? But you also have to have standardized improvement science methodology to improve it if it's not working appropriately. If we do all this, we'll become a institute that's not only highly reliable, but also will exude performance excellence. And I want to thank you, and I'll be open for any questions you may have. I appreciate it.
Adam, good morning. My name is Jigme Sethi, and I thank you for a wonderful overview of quality improvement. I have a couple of questions, and one is about 5 years ago, I read a lot of literature that in any high-functioning organization, you talked about a leadership-driven level 5 organization, that change does not happen unless the board, not the leadership, gets involved. I'm wondering, in your experience, if that's true and how it's held up. And the second question I have is, in all practicality, as we involve more and more people, including residents and fellows, in getting involved in this process of continuous innovation or quality improvement, how do you sift the issue of research from quality improvement, and how do you deal with IRBs in this kind of a situation where there can be confusion as to who touches human data and what their permissions are to do so?
Thank you, Dr. Sethi. I appreciate those questions. First, to the board and senior leadership, it's essential. D&V is our accrediting body, backs that up to where you have to have at the board level, they have to have an awareness of things that are going on for quality and safety and service in the organization. And then it comes down, and that, of course, they set the strategy with senior leadership's help for the organization. The second level of that, or integrated into that first level, really, with the board is the chief officers, both on the medical side and on the hospital side. We're lucky to have great leadership in both regards that really understand quality and safety and really drive those strategic objectives appropriately. And that propagates itself. Things are put in place where there's accountability structures, and that works. It can always be strengthened. And we always will be strengthening that over time. So it's an essential piece. And the more it happens, the stronger it gets. But the more you standardize and have these methods in place, and that really gets to the quality management system, it strengthens itself over time. The second part of the IRB piece and how we delineate this from research is oftentimes quality improvement projects are process oriented. These are done without specific PHI involved or patient information. This is at sort of high level. Yes, we have to look at maybe specific reasons why there are readmissions and so on and so forth. But those are usually done in a protected manner, or always are done in a protected manner. How that delineates over into IRBs is, of course, IRBs have different structures. One for pure research, that is human studies, where you're randomly sampling subjects and you're having consent forms and things like that. Quality improvement is often done at a higher level where there's no consent needed and things of that nature. And it's really put through IRB if needed through a quality improvement cycle on that piece. I hope that answers your questions.
Thank you.
Yep. Any other questions? Happy to answer. You see on the bottom of the screen, that's my email address. Please reach out anytime. Happy to talk about these concepts, training opportunities for your staff, for yourself. It's very important that we have this throughout the enterprise. And I'm here and happy to help in any way. And I know several on the call are as well. Any other questions?
Dr. Campbell, it's Jeff Bennett. Thank you very much. This is a nice, I think, package that describes a model end to end, and you get down to a little bit more of the fine detail at the end in terms of the approach, at a individual clinic level or operational level. Your key driver diagram in the slide deck seems to frame how within a given clinical operation, with a high level goal, something that's, maybe a little bit more long-term part of a organization's, strategic model, you can break that down into interventions, which each and of themselves could be fairly robust project opportunities. And to your knowledge, within the organization, do we have many of these kind of delineated, in terms of taking a strategy, identifying where in given clinical areas we might be falling short of a strategic aim, and then, breaking it down in this way? Or is this going to be a forward part of the work?
I think it's both, Jeff, and I appreciate that question. The first part of that is the identification of the problem. We have no problem with that. Any institution, any system usually does a great job of surfacing issues. It really is the next piece of that, which is the prioritization of the risk, right? Identifying the high risk, no problem, but how do you prioritize where you're going to put your energies? That I think we're doing a decent job at, but it's the resource issue. And when you have resources, whether it be training or staff-wise, you really have to pick the ones that you think have the highest degree of potential to affect the patients and affect outcomes and processes most readily. So we have that. I think what we need on the back end, okay, I'll preface this by saying we do a great job of surfacing these issues, but it's the prioritization and it's the standardized methods to which we achieve performance improvement. So I think the more we train, the more we get people involved, the more they see that they can be in charge of making these differences occur, I think we'll get a lot of momentum. And I think we're getting that momentum. I think we'll continue to do that over time.
Adam, this is Alan Court. I was just wondering if you could discuss a little bit how your department will actually help the residents and what is available for residents as they start to develop their projects and what kind of guidance you can give them.
Right. Thanks, Dr. Court. I appreciate that. A couple avenues. One is being trained in eSafe, knowing how to put problems into the system that can be fixed. So there's a high degree of interaction that can occur there. And I think we do a good job of that through the team and our interaction. The second part of that is being able to see the outcomes of root cause analyses and being involved in root cause analyses where it's appropriate. This is something we continue to improve with the residents and even fellows and staff in general. I think that occurs because the way root cause analyses occur is if you're involved in an event, we wholeheartedly want you to be involved in the solution to the problem. So residents, fellows, staff will be involved in those scenarios. The other piece of that is, of course, the quality improvement project requirements. And I say requirements because there's a requirement aspect to it, but these are things we should want to do intuitively. That's where I think we have to have that decentralization. I know I'm talking with others, with Jeff and others yourself, about how we can have training for residents and fellows and decentralize it in that manner. I think we're working toward that, and we'll definitely strengthen that for the future. But I think those are the main avenues through which we can increase the resident and fellow aspects of this.
So, Adam, you're saying that your department, though, is available, as it has been in the past, to provide consultation and coaching for residents as they do projects.
Oh yeah. I'll do that personally, Dr. Court, you know that. So I know there's others in the organization. I know, like the safety team can get you up on eSafe and make sure things are running smoothly there. So that's something we do, and I can provide coaching on any given project or do workshops. Yeah.
Thank you for that presentation.
Sure, I appreciate that, Dr. Court. Thank you. Any other questions? All right, if not, I am available, of course, through email, through phone, 5379, give me a call. And I appreciate everybody being on today, and we look forward to being able to help you any way we can. All right, have a good day. I appreciate everyone. Thanks.